So good morning everyone. So without wasting much time, both of my colleagues have their separate other presentations. So I'll be talking upon orbital fractures, what implant suits your patient the best. So just to give a brief background, we have come a long way. The orbital fractures were first described by Mackenzie in 1844, and then in 1957, Smith and Reagan, they described the blowout fracture, and then various authors described different implants for correction of orbital fracture repair. So when we choose an implant, the key factors are the timing of surgery, the surgical competence of the surgeon, and then choice of implant is what I'll be talking upon. So in our life, when we look for our match, so these are the things that generally we look upon, that our life partner should be compatible, she should be or he should be non-irritating, flexible, supportive, available for you in difficult times. Some people also think of figure and contour, and then the wallet size also matters. So when we transpose these factors to the orbital implant, we see that similar to our choice of an ideal partner, these implants should also be biocompatible, they should be non-allergic, flexible, they should support the ocular structures, and yeah, of course, they should be available in sufficient quantity. They should be easy to contour along the orbital walls, and yeah, and they should be cost effective in the Indian scenario. So what are the other available options? We have a lot of options for orbital implants, ranging from autologous, allogenic, xenograft to alloplastic, different alloplastic and polymers. And right now we have also a composition of different implants together, which is known as composite implants. So what are the factors which influence our choice when we decide upon going to repair a fracture and think upon what implant we should use in the particular case? So of course the important thing is the defect size. What is the size of the defect? What is the amount of inophthalmos? Is there are there multiple walls involved? Adaptation to internal contour. Do we need to restore the volume, or just that diplopia or EOM we want to correct? And whether it's an early fracture or whether it's a fracture which has been there for quite a long time. So just to briefly describe few cases, this is a patient who presented post-trauma. As you can see here in this picture, there's a limitation of movement in the upward gaze, and this is her CT scan, coronal, axial and sagittal view, and you can see it's a typical teardrop sign where the blowout fracture has given way and then snapped back to its position, entrapping the inferior rectus muscle in the process, and that's what is causing the elevation limitation. So in this particular case, what you don't need a volume restoration, just need to release this entrapped muscle and put something there so that it doesn't go back. So that's what we did. We released the muscles, and here we have put an osteomesh implant, which is an absorbable implant. And this is the post-op result. You can see that elevation has quite nicely almost come back to normal. This is the second case. So it's a 13-year-old boy who complains of diplopia post-accidental fall. And as you can see in this picture here, there is a limitation of adduction in this eye here. And this is the CT scan picture. Typical, the most common location for orbital fracture, the inframedial wall, which has fractured, and some of the orbital contents have herniated there. So here in this particular case also, you don't need much of a volume. So here also you can see post repair, the adduction has very nicely corrected here. EM almost has become full here in this picture. And we generally do post repair imaging for all our cases to see what is the position of the implant. Has it gone inside nicely, whether it's resting on some important orbital structures or not. And we put a titanium implant, and you can see it's very nicely placed, and in the sagittal section and both in the coronal view also. This is a 3D image. And so now this is a case where you typically need to restore volume here. See, large blowout fracture, almost all of the content is in the orbit. And this is the post fracture repair. Inophthalmos has been nicely corrected. And another case, both of them where you need to restore volume. Here also see, there is a large fracture of the floor. There is a lot of inophthalmos here. So in these cases where you need to restore volume and the fractures are quite large, so these cases you can put a composite implant, which we generally use bone or like a titanium plate implant over a bone. So here an onlay has been given. This is the iliac crest, bone harvested from the iliac crest, and over there we have put a titanium implant to restore the volume. And as you can see here, the volume has nicely been restored. So where you need to typically put large amounts of volume, you can put a composite implants like this. Now this is another case, a challenging case which we recently encountered. This police inspector from Bangladesh injured in a bomb blast. So this is an artificial eye. A scleral shield has been placed here, and lot of psychiatrical changes in the lower lid also. But what is important is this 3D recon image of the patient. You can see this is a typical quadrangular quadripod fracture, as we call it here, where the lateral wall has been disrupted at the ZMC, at the zygomatico-sphenoid suture. The maxilla has got detached from the zygoma, and there is a floor fracture also. So tripod plus a floor fracture, a quadripod. So in this case, you have to do a typical 3-point fixation. That's what we have did here. So you can see here the lateral wall has been replaced by small mini plates and screws, and then we have just tried to contour the floor here. The rim was missing. It was an impure fracture. So we have to try to put recontour the rim by putting a mini plate here also, and then we have joined the maxilla with the zygoma by the intraoral route. And this is the post-op image. See that the inophthalmos and all has nicely been corrected, and this is the post repair imaging. All the plates and screws in place. Now this patient he needs a repair of the soft tissue, the psychiatrical part. So another case here. So just again a blowout fracture of the medial wall. The whole medial rectus has gone into the ethmoid sinus. So in this case also you don't need much of a volume. You just need to go and bring this medial rectus in its original position. So what we used in this case are X-ray film. So X-ray film also can be used. You can sterilize them and contour them, and because in cases where you don't need much of a volume, you can even use a X-ray film. So this is the last case here. So this is a post-op image actually. So you don't see much of inophthalmos here. There was not no movement limitation. Diplopia had nicely corrected, but then patient was not convinced that there was no scar mark. How did such a large implant go inside? So we would only do this thing, post-op imaging. So for this particular case also we did a post-op imaging, and we showed him the implant. So just to emphasize upon that, most of our MaxFax colleague, they take the incision, they take a subciliary incision, which actually results in a psychiatrical ectropion. But that's the advantage of a subconjunctival incision, that it's also cosmetic and it doesn't give you that tethering effect that's there in the subciliary incision. So just to conclude, a surgeon's view or the surgeon's view of an implant. So it should cover the entire defect. It should conform nicely to the walls, and it should match the volume of the uninjured orbit. And it should not migrate, that it should nicely support. It should not cause hypertropia, that you are not placing the implant over some extraocular structures. And it should not necessitate removal or debulking that like commonly happens in large bone grafts, like some of the MaxFax they generally put it. So this is just a review of different implants, like all the factors they have taken into account, and they have compared like what implant gives you the best of what factors. So as I said, that the perfect match, the choice of a perfect match, like we keep looking upon, and it's not like we can decide upon a single case that okay, I'm going to put such and such implant for all my cases. You have to customize your implant depending upon the size of fracture, the functional defect, and the need of the patient. Okay, thank you.